and welcome to 360RN. Thank you so much for studying along with me today. My name is Dr. Meredith Watkins, and it's my job to make nursing education material simple and easy to follow. In this video, it's part of our series on mental health nursing, and we're going to be talking about the different roles that a nurse has in the mental health care system and the care environment. Where does mental health care happen? Now, nursing in mental health can feel kind of intimidating to a new nursing student. It's very different than the med surg that we're used to. So I hope this video helps to ease your anxiety and build to your knowledge base on mental health nursing. Be sure to grab the Mental Health Study Buddy workbook. It's down in the description box below. It'll help you get the most out of this lesson. Without any further ado, let's jump into it. There's a number of things we're going to accomplish in this video. So in this video, you're going to learn the purpose and elements of the therapeutic milieu. You're going to learn assessments of escalating behavior, how to recognize when patients have escalating behavior, how to de-escalate patients. We're going to talk about the trauma-informed care approach. We're going to talk about collaborative interventions at both primary, secondary, and tertiary mental health care levels. We'll talk about the roles of the nurse in mental health, and also the collaborative care team that helps support mental health patients. Now, nursing roles in mental health care can be divided into three different categories. You can consider the traditional role of the nurse, the therapeutic relationship that the nurse has with the patient, and then finally the role of the nurse as an advocate. So under the traditional roles, it's things that we're more familiar with using perhaps in the med-surg type environment. Following the nursing process, and that means assessing and identifying problems and intervening and then evaluating how the interventions went. Educating the client on their disease or illness and their medications or therapies, what to expect. Managing their care, deciding what referrals have to be followed through on and how to support the patient and making sure that their whole collaborative care team is working together. Medication administration, of course, assessments, and documentation. All of these things we're very familiar with as nurses. This is part of what we do in the traditional sense of a nursing role. The therapeutic relationship is something we talk about in all aspects of nursing, but it's perhaps more elevated in mental health nursing. The therapeutic relationship includes therapeutic communication. Therapeutic relationship is goal-oriented, so it's a relationship focused on helping the client achieve their health goals and their mental well-being goals. It provides encouragement to the client because the client is the one who really drives their wellness and drives their healing process. We're there to support them. And it reinforces the things that they're being taught or asked to do by their provider team. And then as an advocate, we're going to assess the patient's access to healthcare, note any disparities that they have that are limiting their resources and could potentially cause poor outcomes, and finally help make any referrals that are needed. So you can see that the nursing role is traditional in a sense, and then also expanded for mental health care. There are a number of people on the patient's collaborative care team in mental health. The first is the person who is going to diagnose the mental health disorder. And there's two different roles that can do that: the psychologist and the psychiatrist. A psychologist is not a medical doctor, but they do have a doctoral degree, either a PhD or an Ed.D. And the psychologist can help to interview patients, diagnose, and provide counseling to patients. A psychiatrist is a medical doctor who can also diagnose, and in their role, they can prescribe medications. So both can help patients come to having a mental health diagnosis. One can provide counseling and the other provides medication. Now, there are other people on the collaborative care team. Behavioral health technicians work on inpatient therapeutic milieus, inpatient mental health care environments, and they kind of run the show on the therapeutic milieu. They'll run group therapy sessions, they'll oversee meals, they'll oversee the general well-being of the social setting of the therapeutic milieu and ensure safety. They'll also do the Q15-minute checks on the unit to make sure that all the patients are safe. Social workers are a big part of the therapeutic milieu. It's important that when patients are discharged from the hospital that they have a safe place to go and a follow-up plan, and social workers are the ones who do that. Occupational therapists will come to the unit and provide certain activities for the patients. In some places, they oversee the grooming hour each day. Now, obviously, things like razors aren't things we're going to provide to patients if they're on suicidal watch or if they're having psychosis. But during the grooming hour, they can provide those resources like nail polish and perfume and razors to help the patients complete their activities of daily living. And the occupational therapist is the one who usually runs that session. Counselors or therapists can help with psychotherapy and help the patients work on their healing. The pharmacist is the one that oversees the distribution of the medications that the psychiatrist has provided and handle any contraindications or problems that the patient's having with the medications. Case managers are helpful for patients with serious mental illnesses that are going to have these illnesses chronically. They can help manage the patient's overall health and keep them supported while they're out living in the community. And then finally, we can't forget about the caregivers and the family of the patients and the integral role that they often play in supporting the patients in their journey. Now, it's important to remember that when we're working in mental health, we're talking about a person's beliefs and emotions and feelings and histories and traumas, and that's a very interpersonal type of relationship. And so more than ever, it's important to maintain professional boundaries as a nurse between the nurse and the client. And there can be a couple challenges that happen with that. One of them is called transference. Transference is when the client displaces feelings about someone else and puts it on the nurse. And so that would be things like, oh, you remind me of my mother because she was so nice and so kind and always warm and welcoming, and starting to consider you as their mother. This can also go a different direction, where maybe the client has had negative interactions with healthcare providers in the past, and you start hearing the client say, you're just like that last nurse I had. I hated that nurse. I couldn't stand them. And these are challenges with being able to provide therapeutic care. And so if you notice transference happening, it's wise to move that patient to having a different nurse. Now, countertransference is something else to be aware of, and this is when the nurse displaces feelings toward the client. And so countertransference can be the same thing, it's just which direction that transference is happening. And again, it's wise to have that client move to a different nurse if that's the case. And then we want to be mindful of casual familiarity. Remember, these patients are not our friends. These patients are in our care as clients to help them move toward their healing process. And so we want to focus on the therapeutic relationship, focusing on the client's goals, and focusing on the client. So continue to maintain that level of professionalism and professional boundaries as you interact with the clients. Here are some different guiding professional principles that can help us maintain those boundaries. The American Nursing Association Standard of Practice, the Nurse Practice Act, which is state-specific. Each state has their own Nurse Practice Act, the ANA Code of Ethics for Nursing, and then laws and policies at all levels, local, state, and federal. When we consider providing care to a client, we want to do so in a trauma-informed care approach. Trauma-informed care is a rather new approach to mental health, and it really says that behavior comes from a cause. So whatever behavior you're seeing from the client has some sort of trauma base or cause that the patient is experiencing. And so this helps us to provide care in an empathetic way, focusing on helping the client to heal past traumas. So it focuses on understanding past traumas and preventing future traumas, being patient-centered, developing compassion, being supportive, and considering issues that could be traumas in the patient's history. Things like systemic racism or historical racism, ACEs, which are those adverse childhood events, disparities, their cultural differences, and gender. All of these issues can cause past traumas, which could lead to the behavior you're seeing today. So if we get down to the root cause, we want to focus on healing that rather than just modifying behavior for today. Here are some common themes we see in challenges in providing care to the patients in mental health. We can have problems with providing culturally competent care. Recognizing that the patient's values, beliefs, and family background all play a role into how the patient sees the world and how they perceive their mental illness. We want to provide care that's meaningful to the patient and aligns with their cultural values and beliefs. Workplace violence is a growing issue in all aspects of nursing, including mental health. And we want to make sure that we are working in safe environments for us and for the patients. Health disparities are also a problem in providing care, and we see problems with providing equitable care. We see outcome differences in certain vulnerable populations. Populations like veterans, people in rural areas, the LGBTQ+ community, and so on, can have disparities in their mental health outcomes. We see challenges with affordability. Some patients have insurance, others don't. Even with insurance, it can be very expensive to have medical or mental health care. And then finally, accessibility. We see challenges with accessibility in especially rural areas, or just with the lack of the number of providers needed to provide care for the 23% of Americans who have mental health illness. Let's take a little time to talk more about culturally competent care. Culturally competent care, or cultural competence, is the ability to deliver services that are respectful and responsive to the health beliefs, practices, cultural, and linguistic needs of diverse patients. A lack of culturally competent care can arise from a lack of shared culture or language, a lack of shared values, or different gender identification. And sure, cultural competence helps the patient feel more comfortable. That's definitely part of what we want to do. But it's more than just making the client feel good and feel welcomed. Patients who don't receive culturally competent care are more likely to be undertreated, have a lack of belief in the healthcare system, or be believed for their complaints, their medical complaints, and the patient may be hesitant to seek care. Because of this, it's so important that as mental health providers that we continue to improve and grow in our ability to provide culturally competent care. Care that is understanding of the patient and takes into consideration the whole patient, all of their beliefs, values, history, and culture. The ways we can improve in our ability to provide culturally competent care include be a lifelong learner, continue to learn about other cultures, have cultural humility, recognize that our culture isn't the center of the universe, and that we want to grow in knowing about other people's cultures and recognize that we don't always have the answers. We want to examine our own biases and personal values. We want to ask the patient what's important to them and how can we support them while they're in the hospital. We want to interact with other cultures. The more we can have interaction, the more we can appreciate different cultures and have exposure and grow in our knowledge of different cultures. We want to acknowledge that disparities and differences happen, and so if we first acknowledge it, then we can address the problem. When we're talking about patients, we only want to focus on relevant demographic information and be careful not to stereotype patients. Another care challenge we see is that of caring with people with serious mental illness. 1 in 25 adults has a serious mental illness, and serious mental illnesses are defined as being chronic, as having dysfunction in daily life, and examples of this would be bipolar 1, schizophrenia, or major depression. Patients with serious mental illness have significant health risks. In fact, they are more likely to die 25 years old earlier than the average adult. They're more likely to face unemployment, have worse medical care, and they're 2 to 4 times higher to have the risks of cardiovascular disease, obesity, hypertension, smoking, stroke, and diabetes type 2. Patients with serious mental illness often benefit from increased community resources and case management to help support them in their day-to-day living and give them the best outcomes. According to the National Institute of Mental Health, there are certain vulnerable populations that are more likely to have poor mental health outcomes. Knowing this can help provide resources to patients if they're in greater risk. These vulnerable populations include the LGBTQ+ community, American Indians and Alaskan Natives, people who are from 2 or more ethnicities, those who are uninsured, unhoused, and adolescents. In healthcare, we talk about levels of prevention, levels of care provided for a patient. And these levels of prevention can be divided into primary, secondary, and tertiary, or PST. P for prevent, S for screen and treat early, and T for treat long term. Let's break this down a little bit more. The first level of prevention or level of care is primary prevention, P for prevent. So we want to avoid mental health illnesses from happening in the first place. And so in primary prevention measures would include things like drug abstinence programs in schools, social emotional learning curriculum in schools. And here the focus is really on children, because a lot of mental health illnesses stem from childhood events. And so if we can reach out to children and support them during their most formative years, we hopefully can prevent some mental illness from happening in the first place. S stands for secondary, or screen and treat early. The idea here is to catch mental illness early in the process before it becomes too bad, screening them for those symptoms, and then providing early treatments. The idea is that it won't progress to be as bad if we can catch it early. So examples of secondary prevention include early education interventions and suicide screenings. And the third level of prevention is tertiary, or T for treat long term. So these are patients who have already established mental illnesses, and they're going to have these chronic mental illnesses for a long time. And the goal is to help manage those mental illnesses so that they don't get worse and that they can have the best outcomes or treat them long term. Things like adult daycare for adults with lower levels of cognition, or providing case managers for patients with serious mental illness. Care settings for mental health care can be provided either in the inpatient or outpatient settings. Outpatient is preferred as it is a less expensive option. Outpatient settings can include the primary care doctor's office, mental health clinics, telehealth, where you pull up an app and talk to a counselor right on your phone, home health visits, day programs, and family support groups. Inpatient settings can be used either in the short term to help alleviate a mental health crisis in a patient, or long term for patients who require longer term support. These inpatient settings can include substance detox programs, treatment centers, state-run mental facilities, private hospitals, court-ordered inpatient stays, which we also call forensic, veteran care, and then specialty populations for things like geriatrics and pediatrics. When a patient's admitted to inpatient mental health care for a mental health crisis, they're admitted into a secured environment called a therapeutic milieu. Milieu is a French word meaning environment. So a therapeutic milieu is a healing environment meant to help the patients through their crisis. It's an environment that is structured, supervised, and provides safety to the patient and those around them. The environment is very controlled, and the focus is on activities of daily living, coping skills, social skills, safety, and a predictable routine and environment. So the first consideration when we're talking about the therapeutic milieu is the physical environment itself. Now, the goals for the physical environment are to provide safety, to reduce stimulation, and to have a controlled environment. The organization of the physical environment includes typically a day room where community building can happen, an environment with reduced noise and stimulation and reduced lighting, offering privacy to patients where they do have private or semi-private rooms for sleeping. They want to make it a home-like environment so that it can provide a healing environment for these patients. And then finally, we want to reduce physical safety risks to allow autonomy within. So if the patient is at risk for suicidal ideation, having an environment where they can freely go within the environment, to the day room, to their room, down the hall, and they can move freely within that environment because the entire environment is set up for their safety. Every single lock, every door, every light, every piece of furniture has been intentionally developed so that there are no risks in the environment. In addition to the physical environment, you need to consider the psychosocial environment of the therapeutic milieu. The goals of the therapeutic milieu are coaching, providing feedback to the patients on how they work through using coping skills, interactions between the patients and the staff, and every one of those small interactions can help the patients move toward healing. Having a supportive environment and providing boundaries and structure for the environment so that there's clear expectations. The organization of the psychosocial environment includes having rules for the environment, and patients are briefed on those rules when they first are oriented to the unit. So when they're first admitted to the unit, it's important that the nurse sits down and says, here are the rules for our unit. These are the things that we all agree to, and they're community guidelines to keep our community running smoothly. The organization also is going to support the patient's rights and provide them as much autonomy as they can within those boundaries and rules. This psychosocial environment focuses on having the clients accept responsibility for their own recovery. This isn't something someone else can do for them. We come along as healthcare providers to help assist them on their journey, but the patients have to be the ones to do the healing. And then finally, if it's the focus on interpersonal relationships. We know that isolation is not good for our mental health. And by having these community-based organizations, these community-based day rooms, it can help to foster better mental wellness as you're part of a community. Here are some guiding principles for a therapeutic milieu. First is safety. Safety is the number one priority. There will be security on the unit will be locked, there will be multiple monitors. They do Q15-minute checks on all patients throughout the environment, and every aspect of the environment is controlled. So the lights, the tables, the beds, everything that they use is intentional to avoid any opportunities for ligature or self-harm, and it's really about keeping the patient safe within this environment. The next is patient dignity, and it's really about balancing autonomy with safety. The next is predictable routines and schedules. Having a routine and a schedule is very healing for the patient's well-being. And then the last one is that trauma-informed approach, remembering that behavior often stems from a cause, and getting down to the root cause of the behavior can help in long-term healing. Because safety is so important in a therapeutic milieu, there are a number of items that are contraband on the unit. Things like personal clothing. They're not allowed to use their personal clothing. They must use the gowns and socks provided by the unit. Personal phones are not allowed, but they do have access to phones on the therapeutic milieu. Razors, metal utensils, weapons, any items that could be considered ligature items, like lanyards, necklaces, are all banned. And any light furniture that could be picked up and tossed across the room. You'll notice when you go into the community rooms or see the beds that the beds are actually bolted down to the floor. And in the community rooms, the chairs are extremely heavy so that they can't just be tossed across the room. When you're working in a therapeutic milieu, it's important to be picking up on the cues that the patients are giving and recognizing any escalating behaviors so that you can intervene quickly to provide safety and also de-escalate the patient. Signs of escalating behavior by a patient can include verbal signs like talking loudly, swearing, or using a threatening tone. Or there can be nonverbal cues of escalating behavior, clenched fists or jaws, staring or rapid eye moving, pacing, heavy breathing, or holding their arms tightly across their chest. When you notice escalating behavior, you want to intervene as soon as possible, because the sooner you can intervene, the more likely the patient still has use of their logical reasoning and can make different choices. Verbal de-escalation tactics include offering choices. I noticed that you seem very upset at the moment. Would you like a shot or a pill to help you calm down? Would you like to go to your room and color, or would you like to go to your room and read? Create space between patients. If two patients are butting heads and bothering each other, have one go to one room and someone go to another room to just give them some space. Keep the fair rules. If patients feel like they're not getting treated fairly, that will cause an escalation. Maintain a calm demeanor no matter what. Listen to the patient and validate their feelings. Often just validating a patient's feelings can really change their behavior. Offer distraction. Hey, let's go do this. Let's go turn on the TV. Let's go color. Consider a timeout where the patient has a choice to go to their room and take a timeout. And offer PRN medications as needed. Now remember, physical de-escalation is going to be the last resort, but sometimes physical de-escalation is required if the patient has come at you and is assaulting you. Physical de-escalation techniques require specific training, and when you work on a unit like this, you'll get training usually annually on physical de-escalation tactics. The biggest thing to know is that you need training to do physical de-escalation and that you act as a team. You would never do physical de-escalation on your own. As a nursing student, your first day on an inpatient unit on mental health can feel really intimidating and maybe a little overwhelming, but I hope these tools give you the knowledge you need to get a strong start. Thanks so much for studying with me today. Remember, you are smart, you are capable, you are loved, and you got this. I'll see you next time.